Today I'm going to talk about SMART syndrome. So SMART syndrome is a stroke-like migraine attacks after radiation therapy, and it's considered to be a rare complication of intracranial radiation. Couldn't find exactly how much the incidence of it, but the first case series was reported in 1995, and it was reported by Schuper, and was reporting 4 kids who had a posterior fossa tumor, and following that had radiation, and it was reported as complex migraine attacks after radiation therapy. Typically seen after cerebral radiation, instead of beam radiation, and it's usually about 50 gray. But this is not a hard rule. There's some case report where they had less than that. The typical onset usually by a few years, 3 to 5 years, but again, this is not hard rule. There's some case report where it started 1 month after radiation and sometimes after a few decades after radiation. It's considered to be a clinical radiological diagnosis. And usually the clinical features of SMART syndrome is stroke-like deficits where you get dysphagia or hemisensory loss or hemiplegia or visual symptoms. Seizures is commonly reported, and migraine attacks. Of note, just stroke-like deficits usually is more of subacute onset, taking hours and days, and it's usually transient symptoms and signs. The hallmark and radiological features is the MRI findings of gyral enhancement, and it's usually time sensitive, so it takes some time to get the features appear on the MRI between 2 to 7 days. It's usually the gyral enhancement. T1 usually find early on low signal changes, and then after that you can get sometimes hyper-intense signal changes. T2 and flare also hyper-intense signal changes, and DWI is not very helpful, sometimes variable diffusion restriction. And you can see T1 contrast, you can see prominent gyral enhancement with differential enhancements sometimes. In CT, usually just find hyperintensities, so it's not very much helpful. And usually you need a follow-up MRI to see if there is the transient findings are disappearing. There's some suggested diagnostic criteria in 2006, but it's not really very much. Just you have to exclude any other causes. You have to have a remote history of extended beam radiation. You have to have a reversible, so it's a retrospective. You have to have a reversible sign and symptoms with unilateral cortical regional involvement, such as hemisensory loss, hemiplegia, confusion, aphasia, seizures, and migraine attacks. And the MRI findings we talked about is usually transient diffuse unilateral cortical enhancement, sparing the white matter. But this is not a hard rule. The first case was reported in 1995. There was not any new changes in the MRI, so it's not all the time the MRI findings. In terms of the pathophysiology, again, it's not very well understood. Some proposed mechanism is transient vascular reactivity with thrombus formations or vasospasm, and also the cortical spreading phenomenon we see with migraine is suggested. But on autopsy, is just non-specific gliosis what's being found. The differential diagnosis you need to consider usually in these cases is hemiplegic migraine in young patients, breast stroke, and epilepsy. Sometimes we need to have EEG. Tumor recurrence is also needs to be excluded before we make this diagnosis. The majority of cases tend to result in 87% in one of the case series. They have complete recovery, but incomplete recovery is also in minority of them, as some patients have permanent deficits. In terms of treatment, it's usually spontaneously resolved. Symptomatic treatments in terms of migraine treatment or seizure medications can be offered. In one case report, there was a steroid given, but it's not very well validated. And that's all.